Chapter 3: Disorders of Perception. Disorders of perception can be divided into sensory distortions and sensory deceptions. In sensory distortions, there is a constant, real perceptual object, which is perceived in a distorted way. These are the result of change in the intensity and quality of the stimulus or the spatial form of the perception. And in sensory deception, a new perception may occur that may or may not be in response to an external stimulus. Let's first discuss sensory distortions. As just stated, these can be due to changes in intensity, changes in quality, or changes in the spatial form, also known as Dysmegalopsia. Changes in intensity include Hyperaesthesia. It is the increased intensity of sensations. This may be the result of intense emotions or a lowering of the physiological threshold. One example being Hyperacusis. Anxiety and depressive disorders as well as hangover and migraine are all associated with increased sensitivity to noise, such that even everyday noises are magnified to a point of discomfort. Another example is optic hyperesthesia. Those who are hypomanics, suffering from epileptic aura, or under the influence of LSD may see colors as very bright and intense. But this can also be a feature of intense normal emotions such as religious fervor or the unsurpassed happiness of being in love. Hypoesthesia is the decreased intensity of sensations. The example being Hypoacusis in delirium, where the threshold of all sensations are raised. This highlights the importance of speaking to the delirious patient more loudly and slowly. This can also occur in depression and attention deficit disorders. Visual and gustatory sensation may also be lowered in depression. For example, everything may look black or all foods taste the same. Second is the changes in quality. It is mainly the visual perceptions that are affected by this, brought about by toxic substances such as xanthonin, mescaline or digitalis. Predominance of single color has been named as Xanthopsia for yellow, Chloropsia for green, and Erythropsia for red. In derealization, everything appears unreal and strange, and in mania, objects look perfect and beautiful. Now let's discuss changes in spatial form, also known as Dysmegalopsia. This refers to a change in the perceived shape of the object. Micropsia is a visual disorder in which the patient sees the objects as smaller than they really are. Paropsia is the retreat of objects into the distance without any change in size. Macropsia or megalopsia is the opposite of micropsia, that is, the seen object seems bigger than it actually is. And metamorphosia, in this the object seems irregular in shape. Dysmegalopsia can result most commonly from central lesions of temporal or parietal lobes, from retinal diseases such as in edema of retina, visual elements are separated so that the image falls on what is functionally a smaller part of retina than usual. This gives rise to micropsia. On the other hand, scarring of retina with retractions produces macropsia. And if the distortion produced by scarring is irregular, metamorphosia is more likely. Disorders of accommodation and convergence can also cause dysmegalopsia. For example, complete paralysis of accommodation or overactivity of accommodation during near vision is likely to cause macropsia. On the other hand, partial paralysis of accommodation will lead to micropsia. If accommodation is normal but convergence is weakened, macropsia occurs and vice versa. It may also occur in poisoning with atropine or hyoscine. Infections. Nerves controlling accommodation can be affected by conditions such as chronic arachnoiditis. This might also give rise to dysmegalopsia. Seizures. Macropsia, micropsia or irregular distortions may occur either during the aura or the course of fit itself. Hypoxia and rapid acceleration can disturb accommodation and convergence, but dysmegalopsia is rare among high-altitude pilots. Distortions of the experience of time. From the psychopathological point of view, there are two varieties of time: physical, that is the objective time, and personal, which is determined by personal judgment. This personal time is affected by psychiatric as well as organic disorders. Among psychiatric disorders, slowing down of time is most marked in those with psychotic depressive symptoms. The manic patient feels that time speeds by, and schizophrenics believe that time moves in fits and starts, and have abnormalities of time judgment, estimating intervals to be less than what they are. Age disorientation is another feature present in them. Among organic disorders, some patients with temporal lobe lesions may complain that time either passes slowly or quickly. Coming on to sensory deceptions. These can be divided into illusions and hallucinations. Let's first discuss illusions. Illusions are misinterpretations of stimulus arising from an external object. In this, stimulus is combined with a mental image to produce a false perception. Illusions are not indicative of psychopathology per se, as they can occur in normal individuals. These are common in delirium when the perceptual threshold is raised and an anxious and bewildered patient misinterprets stimuli. While visual illusions are the most common, they can occur in any modality, for example, auditory illusions. In this, a person hears words in a conversation that resemble their name and so believes they are being talked about. In fantastic illusions, patients see extraordinary modifications in their environment, but some psychiatrists believe these belong more in the worlds of fiction than the realm of psychiatry. Example being a patient who looked in the mirror and instead of seeing his head, he saw that of a pig. Trailing phenomena are not strictly illusions, but are perceptual abnormalities in which moving objects are seen as series of discrete and discontinuous images. They are commonly associated with hallucinogenic drugs. There are mainly three types of illusions. The first one is completion illusions. These depend on inattention such as misreading words in newspapers or missing misprints because we read the word as if it were complete. Alternatively, if we see faded letters, we may misread the word on the basis of our previous experience or our interests. The second is affect illusions. These arise in the context of a particular mood state. For example, a bereaved person may momentarily believe that they see the deceased person in someone else. Or a delirious person in a perplexed and bewildered state may perceive the innocent gestures of others as threatening. The third one is pareidolia. In these, vivid illusions occurs without the patient making any effort, and sometimes even against his will. These are usually the result of excessive fantasy thinking and a vivid visual imagery. For example, seeing vivid pictures in fire or clouds. Illusions have to be distinguished from the following. The first one is intellectual misunderstanding. For example, someone says that a piece of rock is a precious stone. This may be misunderstanding based on lack of knowledge. The second one is functional hallucinations. In this, both the stimulus and the hallucination are perceived by the patient simultaneously and can be identified as separate and not as a transformation of the stimulus. For example, hearing voices in running tap water. Let's discuss hallucinations. Hallucinations are perception without an adequate external stimulus, but this definition has two problems. It does not cover functional hallucinations and includes dreams. To rectify this, Jasper suggested the following definition. A false perception which is not a sensory distortion or a misinterpretation, but which occurs at the same time as the real perception. Scan defines them simply as false perceptions. What distinguishes hallucinations from true perceptions is that they come from within, although the subject reacts to them as if they were true perceptions coming from without. And what distinguishes them from mental images is that mental images come from within but are recognized as such. Exception being, individuals with eidetic memory will examine his images as if they were external objects. Coming on to pseudo-hallucinations, these are type of mental images that, although clear and vivid, lack the substantiality of true perceptions. They are involuntary, seen in full consciousness, and are known not to be real, and are located not in objective space but in subjective space. There are two different approaches to the definition of pseudo-hallucinations. The first one is based on insight. It renders the concept of pseudo-hallucination superfluous, as insight itself is on a continuum. The second was based on space, exemplified by Jaspers. It depended on whether the image lies in inner or outer perceptual space. Jaspers believed that these are variants of fantasy or mental imagery. Scan does not use the term pseudo-hallucinations, but does have an item for rating insight and for whether the experience occurs inside or outside the head. Fish argued there is a continuum from pseudo-hallucination to hallucinations, and Leff found out that perceptual experiences of normal people under conditions of sensory deprivation overlap considerably with those with psychiatric patients. In conclusion, the debate rages on, and the importance of pseudo-hallucinations or lack thereof depends upon which definition is picked. Coming on to the causes of hallucinations. Hallucinations can be a result of intense emotions, psychiatric disorders, suggestion, disorders of sense organs, sensory deprivation, or disorders of the CNS. Emotions. In severe depression, the voices are usually disjointed or fragmentary, uttering single words or short phrases such as rotten or kill yourself. While in schizophrenia, voices are often of a persecutory nature and will consist of voices giving commentary on a person's actions. Suggestion. Experiments have shown that normal subjects can be persuaded to hallucinate. For example, seeing light where there is none, when they are given hint that there might be. Similarly, subjects can be persuaded to hallucinate either by hypnosis or by brief, task-motivating instructions. For example, they were first to try to hallucinate a tune and then were told much more must be done as most people can hallucinate if they try hard enough. Though under dispute, suggestion is thought to have a role in cancer syndrome. Coming on to disorders of peripheral sense organs. Auditory hallucinations may occur in ear diseases and visual hallucinations in diseases of the eye, but often there is some disorder of the central nervous system as well. Charles Bonnet syndrome is a condition in which complex visual hallucinations occur in the absence of any psychopathology and in clear consciousness. Is most common in the elderly, are of variable duration and can last for years, and the images may be static or in motion. And negative scotoma are to be found in patients with alcohol misuse. Sensory deprivation. If all incoming stimuli are reduced to a minimum in a normal subject, they will begin to hallucinate after a few hours. In black patch disease, sensory deprivation due to the use of protective patches may contribute to the delirium that follows cataract surgery, along with mild cognitive deficits due to aging. Disorders of central nervous system. Lesions of diencephalon and the cortex can produce hallucinations that are usually visual, but can be auditory as well. Now let's discuss hallucinations of individual senses. Auditory hallucination may be elementary and unformed. These mostly occur in organic states and may mimic noises, bells, undifferentiated whispers or voices, or can be completely organized as hallucinatory voices as seen in schizophrenia as part of the basis of patients' delusions, some organic states such as delirium or dementia. They can even occur in severe depression. Wernicke called hallucinatory voices phonemes. Voices sometimes can give instruction to the patients, called imperative hallucinations. Interestingly, the effect of voices on the patient's behavior is variable. A number of patients have continuous hallucinations that do not trouble them. For others, the persistence of auditory hallucinations cut across all activities so that the patient is seen to be listening and even replying to them. A few patients attribute them to real people in the vicinity and may even attack them, as auditory hallucinations are often abusive. Hearing one's own thoughts spoken aloud is one of Schneider's first-rank symptoms and is known in German as Gedankenlautwerden. It describes hearing one's own thoughts spoken just before or at the same time as they are occurring. In French, écho de la pensée is the phenomena of hearing them spoken after the thoughts have occurred. Probably the best English term would be thought echo, or the alternative and more cumbersome thought sonorization. Due to this, the patient may also complain that their thoughts are no longer private but are accessible to others. This is known as thought broadcasting or thought diffusion, and is best classified as a disorder of thought rather than a hallucinatory experience, since it's not mandatory that the thoughts must be first heard. And as mentioned before, few patients deny hearing voices and assert that people are talking about them. Imaging studies of auditory verbal hallucinations have identified activation of Broca's area, a region classically associated with speech production, and thus it has been suggested that these arise from a disorder of inner speech. Coming on to vision. Visual hallucinations are more common in acute organic states with clouding of consciousness than in functional psychosis. These may be elementary in the form of flashes of light, partly organized in the form of patterns, or completely organized in the form of vision of people, objects, animals, or scenic hallucinations, in which whole scenes are hallucinated like in a movie. In delirium, small animals and insects are most often hallucinated. In Lilliputian hallucination, which usually occurs in delirium tremens, patients see tiny people and objects. Temporal lobe epilepsy may have combined auditory and visual hallucinations. Even scenic hallucinations are common. In schiz, visual hallucinations are uncommon, and their presence should raise doubt about the diagnosis. But late onset cases can have combined auditory and visual hallucinations, playing out scenes from their delusion. In the absence of any pathology, Charles Bonnet syndrome must be considered as the most likely differential diagnosis. Imaging studies have demonstrated activity during visual hallucinations in the extrastriate visual areas around the ventral lingual and fusiform gyri, that is Brodmann area 19. In the more dorsal cuneus and precuneus regions, that is Brodmann area 18, and in cerebellum on the posterior declive surface adjacent to the occipital lobe, as shown in recent meta-analysis. Coming on to olfactory hallucinations. Phantosmia can occur in schiz, organic states, and uncommonly in depressive psychosis. Olfactory reference syndrome. In this, people insist that they smell and base their belief on the behavior of others who they say wrinkle their nose or make references to the smell in their vicinity. In schiz, patients may claim that they smell gas and that their enemies are poisoning them by pumping gas into their room. Temporal lobe disturbances, especially during aura. Patients might complain of unpleasant odor such as burning paint, rubber, or stale cabbage. Interestingly, this might be the only complaint in some cases, especially SPS, leaving the patient to search the entire house, trying to locate the offending object. Padre Pio phenomena. Sometimes the smell may be pleasant, for example, when some religious people can smell roses around certain saints. Coming on to taste hallucinations. Phantagosia can occur in schiz, acute organic states, and depressed patients. Olfactory and gustatory hallucinations frequently co-occur with hallucinatory experiences in other modalities, including touch and bodily sensations. One MRI study found that phantom taste and smell in non-psychotic individuals demonstrated activation in the brain regions for taste and smell respectively, and this activation was suppressed by treatment with typical antipsychotic agents. Coming on to touch hallucinations. Formication is the feeling of small animals crawling over the body. This is not uncommon in acute organic states, coarse brain disease, and cocaine psychosis, in which it is known as cocaine bugs. Other sensations can be the feeling of cold wind blowing, sensation of heat, electric shock, and even sexual sensations. And this, in the absence of coarse brain disease, points towards schiz. According to Sims, there is almost always concomitant delusional elaboration of these. Sims classifies tactile hallucinations into three main types. The first one is superficial, that affects the skin. This can be thermic, haptic, hygric, or paraesthetic. The second is kinesthetic. It affects muscles and joints, and the patients feel that their limbs are being twisted, pulled, or moved. This usually happens in schiz. Vestibular hallucinations, in which there is sensation such as sinking into the bed or flying through the air, are variations of this and are commonly seen in delirium tremens, alcohol intoxication, or benzodiazepine withdrawal. The third and final one is visceral. This includes pain and deep sensations and can be seen in chronic schiz, in which complaints can be bizarre like organs being torn out or flesh ripped away, or delusional zoopathy, in which the patient complains an animal is crawling about in the body. There is always a component of visual hallucinations since the patient feels he can describe it in detail. The sense of presence. It is difficult to classify because although it is not strictly a sensory deception, it cannot be regarded as a delusion either. It can occur in healthy people because of lack of sleep, hunger, religious enthusiasm, or in organic states, schiz, or hysteria. fMRI studies showed activation of frontoparietal area, that is Brodmann area 7, in most of the patients associated with feeling of presence. Hallucinatory syndromes or hallucinosis. These refers to those disorders in which there are persistent hallucinations in any sense modality in the absence of other psychotic features. Following are the main hallucinatory syndromes. First one is alcoholic hallucinosis. These hallucinations are usually auditory and occur during periods of relative abstinence. They may be threatening or reproachful, although some patients report benign voices. These rarely persist longer than 1 week and are associated with long-standing alcohol misuse. Organic hallucinosis is present in 20 to 30% of patients with dementia, especially the Alzheimer's type, and are most commonly auditory or visual. Coming on to special kinds of hallucinations. In functional hallucinations, a stimulus causes the hallucination, but the stimulus as well as the hallucination is experienced simultaneously. That is, the hallucination requires the presence of another real sensation, and the patient can distinguish between the two. Can be seen in chronic schiz, where they might be mistaken for illusions. The second one is reflex hallucinations or morbid synesthesia. It is the phenomena of a stimulus in one sensory modality producing a sensory experience in another. Can occur in normal individuals or under the influence of hallucinogenic drugs such as LSD or mescaline. An example in normal individuals is the feeling of cold in one's spine on hearing a fingernail scratch a blackboard. Next is extracampine hallucinations. In this, the patient has a hallucination that is outside the limit of the sensory field. For example, a patient sees somebody standing behind them when they are looking straight ahead, or hears voices talking from very far away. This can occur in healthy people as hypnagogic hallucinations, in schizophrenia, or organic conditions such as epilepsy. The next one is otoscopy or phantom mirror image. It is the experience of seeing oneself and knowing that it is oneself. It is not just a visual hallucination because kinesthetic and somatic sensation must also be present. Can occur in acute and subacute delirious states, epilepsy, focal lesions affecting parieto-occipital region, toxic infective states affecting basal regions of the brain. In healthy subjects, when they are emotionally upset or exhausted, can be hysterical symptoms, and occasionally in schiz. Interestingly, as otoscopy is often associated with serious organic states, as mentioned above, it gives credence to the German folklore that when someone sees their double or doppelganger, it indicates that they are about to die. There can be two types of otoscopy. In negative otoscopy, patients suffering from organic states look in the mirror and see no image. In internal otoscopy, subjects sees their own internal organs, although this is rare. Coming on to hypnagogic and hypnopompic hallucinations. First mentioned by Aristotle, these hallucinations occur when the subject is falling asleep or waking up, respectively. The term hypnopompic should be reserved for those hallucinatory experiences that persist from sleep when the eyes are open. Hypnagogic hallucinations are about 3 times more common, but hypnopompic hallucinations are a better indicator of narcolepsy. And these can be auditory, visual, kinesthetic, or tactile. Organic hallucinations. These can occur in any sensory modality, and they may occur in a variety of neurological and psychiatric disorders, as described. The phantom limb is the most common organic somatic hallucination of psychiatric origin. In most cases, the phenomena is produced either by peripheral disorders such as lesion of the peripheral nerves or central disorders of medulla or spinal cord. Patient might feel that they have a limb from which they are not receiving any sensation, either because it has been amputated or because the sensory pathways from it has been destroyed. Note: I think there is some mix-up here, as the phantom limb syndrome is a near opposite of the above point, or more probably, it is not a single phenomena but have a few subtypes. Therefore, I am keeping the above text as it is mentioned in the book, but I am also adding what is described as phantom limb syndrome from other sources. Either way, if you have something to add, please comment. So it can also be receiving sensation from a limb that has actually been amputated, and the patient can describe pain or paresthesia in the space occupied by the phantom limb. Interestingly, the perception shrinks over time, but distal parts disappearing more quickly than those that are proximal. Phantom limb occurs in about 95% of all amputations after the age of 6 years. In rare cases with thalmoparietal lesions, the patient describes a third limb. Equivalent perceptions of phantom organs may also occur after the surgical procedures such as mastectomy, enucleation of the eye, removal of larynx, or the construction of colostomy. The patient's attitude towards hallucinations. In organic hallucinations, the patient is usually terrified by the hallucinations. The combination of these with a persecuted attitude makes these patients very difficult to care for, as they might make impulsive attempts to escape from what they perceive as a threatening situation by trying to jump out of windows. Patients with depression often hear disjointed voices, abusing them or telling them to kill themselves. They are not terrified by the voices, as they believe they are wicked and deserve what is being said. On the other hand, the onset of voices in acute schizophrenia is often very frightening, and the patient at times may attack the person he believes to be their source. Chronic cases, on the other hand, are often not troubled by the voices and may treat them as old friends or complain bitterly about them. Patients who are knowledgeable about their illness or who have insight into it may either ignore or deny about their hallucinations. Hallucinations in non-clinical populations. Hallucinatory-like experiences refer to the presence of hallucinations in a healthy population. They have been described as being on a continuum, from vivid daydreams, intrusive and vivid thoughts, to an occasional experience of sound with no clear identifiable source, up to a brief experience of voices. Interestingly, HLEs have been identified in about 5% of general population. More recent work has identified a prevalence of around 7% among children aged 9 to 12 and around 7.5% among teenagers aged 13 to 18. Studies have found that HLEs in non-clinical populations were identified as relating to circumstances or were described as single isolated phenomena, whereas hallucinations in clinical populations, as in psychosis, were bound to the person's identity and that there was a fusion between the self and the world experience. But a study on 21 clinical and 21 non-clinical voice hearers did not find a difference in hallucination-related fMRI patterns. Body image distortions. Hyperesthesia. The perceived magnification of body parts can occur with a variety of organic and psychiatric disorders. When part of the body is painful or when there is partial paralysis of a limb, the affected part might feel heavy and large, as in Brown-Séquard paralysis, peripheral vascular disease, multiple sclerosis, and following thrombosis of posterior inferior cerebellar artery. It may also occur in non-organic conditions such as hypochondriasis, depersonalization and conversion disorders, and anorexia nervosa. Hyposchemia and aschemia. It is the perception of body parts as diminished or absent, respectively, and is most likely to occur in parietal lobe lesions such as thrombosis of the right middle cerebral artery following transaction of spinal cord or in healthy volunteers when underwater. Coro, which is a cultural bound delusional disorder from Southeast Asia in which individuals believe that the penis is shrinking and will retract into the abdomen and cause death. Paraschemia is the distortion of body image and is described as feeling that parts of the body are distorted or twisted or separated from the rest of the body. Can occur with hallucinogenic use, in epileptic aura, and even in migraine on rare occasions. Hemiasomatognosia is a unilateral lack of body image in which the person behaves as if one side of the body is missing. can occur in migraine or epileptic aura. Anosognosia is the denial of illness. One study found out that 58% of those with right hemisphere strokes denied their hemiplegia early after the stroke and refused to admit to any weakness in their left arm even after manifest demonstration of the former. Somatoparaphenia. This is a bizarre attitude shown by some patients to their paralyzed limbs. The limb may be too many, distorted, inanimate, severed, or in other ways abnormal, or even belonging to a specified person. Hemispatial neglect is the neglect of the hemispace on the contralateral side to the lesion when performing tasks. Gerstmann syndrome, which is the lesion of dominant parietal lobe, consists of agraphia, acalculia, finger agnosia, and right-left disorientation.